So just wanted to start off by thanking you all so much for being here today. I'm Melinda Pettigrew, the Dean of the School of Public Health, and I'm here to welcome you to the 2025 Health Disparities Round Table. So thank you so much for being here in person and online. Before we begin, I wanted to first acknowledge that the School of Public Health at the University of Minnesota Twin Cities is built within the traditional homelands of the Dakota people. Minnesota comes from the Dakota name for this region, Minnesota Makoche, which loosely translates to the land where the waters reach the sky. And it's really important, especially at this time, to acknowledge the peoples on whose land we live, learn, and work as we seek to improve and strengthen our relationships with our tribal nations. We also acknowledge that words are not enough. We must ensure that our institution continues to provide support, resources, and programs that increase access to all aspects of higher education for our American Indian students, staff, faculty, and community members. And I also want to take this moment after the land acknowledgement to talk a little bit about words. Many of you have heard me talk about the need to rebuild trust in public health. And it's a good time to think about the words that we use. And when these words shut down conversation, when they disenfranchise, when they don't bring the communities in, we may need to shift our language. I also think it's important to reflect on when words can serve the opposite, when changing words may disenfranchise, when they may erase language, culture, history. And in these cases, I would argue we need to continue to use those words. We have to make that balance, creating inclusive spaces and not erasing the people and the communities that we seek to serve. So the Health Disparities Roundtable is an enduring event. It was started by Dean John Finnegan in 2007. And the Roundtable was designed to bring national and local speakers to campus to discuss emerging issues in health and racial equity, policy, and practice. The Health Equity Working Group was founded in the spring of 2005 with 4 goals: to conduct, promote, and provide greater visibility of health equity research, to strengthen collaborative efforts through research, to create lasting partnerships with community-based organizations, and ensuring that the School of Public Health students and faculty work together effectively in a diverse and multicultural society. We are here today to identify effective policies, practices, and programs that advance health equity. And as public health leaders, we know that the health of women, children, mothers is the foundation of a thriving society. Women's health is not just a women's issue, it's a public health imperative. When we ensure that children have access to proper nutrition, immunizations, and early childhood care, this sets them up for a lifelong well-being. We also recognize that disparities in healthcare access disproportionately impact marginalized communities, and this can serve to deepen health inequities. Our commitment to public health, especially at this time, demands that we advocate for policies, research, and programs that eliminate gaps. Because we prioritize women, mothers, and children, we are not just improving individual lives, we are building healthier, more equitable societies for generations. So I want to turn now just to thank the sponsors and the organizers of this roundtable, the Health Equity Working Group and Community Engagement Subcommittee, thank you. The UMN School of Public Health DEI office, extending my thanks and gratitude to them. The Center for Anti-Racism Research for Health Equity and the Center for Leadership Education and Maternal and Child Public Health, thank you to both of those groups. And the UMN Medical Schools Program and Health Disparities Research. Thank you. So finally, I want to recognize the Community Engagement Subcommittee again for your hard work in planning today's event. It's been great to see you all here today to come together in community. And I will now turn things over to Professor Ellen Demerath, today's moderator, and she's going to introduce today's speakers. So thank you so much, everyone.
Yeah, welcome again. I'm really happy to be here, happy to welcome you to the roundtable. I'm a professor in the Division of Epi at the School of Public Health here, and I do research in maternal and child health, and so it's really an honor to be here with our amazing speakers who I'll introduce. And thanks to the organizers, Dr. Toure and Dr. Nong, for inviting me to be a part of this today. And I just before the introductions, I'd just like to take a moment to acknowledge that we're in a space right now which is very, very uncertain. Those of us working in public health in general, but also specifically around issues that we're talking about today, are in a state of total disorientation. Our work is vilified in many ways. People are literally at this moment, in government, in nonprofit, in academia, are losing their jobs and their ability to do their work through cuts and just the narrative that we have here. So I just need to take a moment to just kind of we're here, and it's amazing we're here, and we need to be here together because we need to keep doing the work. We know the work is just, the work is right, the work is good. We're being told it's not, but it is good, and that's why we're here today. And so that's what we're going to be able to enjoy together, is that strength and hearing from our experts who are going to be able to help us remember the why. I just wanted to say that for grounding. So we're going to have three amazing speakers. We have, first of all, so I'm going to introduce all of them at once, and so they'll be coming up one after the other, and then there'll be a long time for Q&A where I hope you will, lots of questions from the floor, from those online. So just so you know, we won't be having questions right after each speaker, so I'm going to introduce them all right now. So first will be Dr. Sharla Smith. Dr. Sharla Smith is an associate professor of population health at the University of Kansas, KU Medical Center. She earned her MPH in health policy management and a Ph.D. in health systems and services research at the University of Arkansas. Her research focuses on maternal and infant health disparities, women's cancer disparities, and community engagement. Dr. Smith is the co-founder of the Kansas Sisters and Brothers for Healthy Infants and the founder of the Kansas Birth Equity Network. She's committed to advancing birth equity through community engagement, empowerment, and education. And in addition to her research, she's a teacher. She teaches numerous master's and PhD students in courses and guides their research. And her passion for public health and birth equity drives her work, not only in the classroom, but in the community. Our second speaker is Noya Woodrich. Noya Woodrich has a deep commitment to child public health. She's an Athabascan, Alaska native. She serves her native community in Minneapolis, where she found her passion for maternal and child health, specifically around preventing infant mortality. She earned her bachelor's and master's degrees in social work from Augsburg University and is pursuing a PhD in public administration at Hamlin. She's currently the Division Director of the Child and Family Health Division at Minnesota Department of Health, where she directs foundational programs that are so important to supporting and improving the health of women, families, and children. Prior to MDH, Woodrich was the Deputy Commissioner at the Minneapolis Health Department, where she supervised the Maternal Child Health Division, the county's opioid and homeless responses, and was incident commander of the COVID response in Minneapolis. Before that, she served as the Executive Director of Health and Human Services for the Mille Lacs Band of Ojibwe and worked with the Division of Indian Work for more than 20 years. Third, we will be hearing from Dr. Asha Hassan. Dr. Asha Hassan has recently joined the faculty of the University of Minnesota Medical School. She's an assistant professor in the Department of Obstetrics, Gynecology, and Women's Health, and is the Director of Health Services Research and Evaluation at Planned Parenthood North Central States. Dr. Hassan earned an MPH in maternal and child health epidemiology and a PhD in health services research policy and administration from the University of Minnesota School of Public Health. Her research explores the link between structural racism and family planning access and decision-making. She examines police violence as a form of structural racism and its impact on reproductive health, and assesses how disability intersects with reproductive justice in clinical policy. She received the Society of Family Planning Next Generation Award in 2024 and numerous other awards. So join me in welcoming the three speakers, and we'll have Dr. Sharla Smith come first.
Greetings, everyone, and thank you for allowing me to join you virtually. I hope that you guys can see me and hear me. I'm grateful to be here, grateful for the honor to speak at this great event. Are you guys going to share my slides or will I be sharing?
Yeah.
Sure. You can share it from your computer.
Okay. Move it over.
Could you hear that I believe you can share?
Yes, I just had to move it over so I can share.
Sure.
Please bear with me a moment while I get these ready to share with you. Okay. Hopefully you guys can see that. Please let me know if you can see the slides.
Yes, we can see them.
Okay, great. Thank you so much. Great. I am grateful to be here again. I'm Sharla Smith. I am an associate professor at the University of Kansas Medical Center and also serve in several roles related to policy and equity. I'm today going to talk to you about the Kansas Birth Equity Network's vision for community healing and justice. And so, as we go through this conversation, I just want to say that there's a reason that we're here, and thank you for being here. But today, we're going to go over maternal and infant mortality. We're going to also talk about the why and who we are as a Kansas Birth Equity Network and our approach to justice. So you may be asking yourself, why this large conversation around justice? And you might also be saying, why this person on the screen is talking to us about justice at this very difficult time? Well, I'm glad that you asked that question because I want to provide an answer to that. So in 2024, Black women were 3 to 4 times more likely to die of pregnancy-related complications than any other woman in the United States. If you want to know why justice, we can just clearly ask Dr. Shalon Irvin's family, who lost her 21 days after giving birth to her daughter from preeclampsia after seeking care for up to 4 times. We could also ask Dr. Shanice Wallace's family, who died in 2020 from pregnancy complications of preeclampsia. We could also ask Tori Borey, who also died of pregnancy-related complications early in life. Or we could ask our own Chiefs cheerleader, who also died shortly after having her baby of sepsis. Out of these women who did not suffer from any of the social determinants of health that we've defined and did not have a reason that we could clearly define as to why they lost their lives of a preventable condition, and the CDC tells us that over 80% of these are preventable, only one person survived. A world-known athlete, one of the best athletes in the US and across the countries. Serena Williams saved her own life after giving birth by advocating for herself because she could not breathe after the birth of her daughter. And so as a community, as individuals who care about human beings, we have to seek justice for these individuals who don't have the things that we define to be causes of death, but die unexpectedly of a preventable condition. We also have to think about justice in a way where we acknowledge the historical perspective of this mortality. And the historical perspective is simply that we in the United States often talk about the father of gynecology and the experiments that the father of gynecology did on the Black bodies to perfect the fistula. But we often forget about Dr. Prevost, who actually did surgery before Dr. Marion Sims and did it to perfect the cesarean. And so when we acknowledge the history of this, we see that Black women's bodies were exploited on to perfect the thing that they are more likely to die of. So we need justice, because how does the Black body perfect the procedures to save lives, but their lives are not saved? So we see that in the history of that, we see that policies have been discriminatory. We also see those conditions around cardiovascular health that simply are areas of stress for our Black families and the Black body. So we also see that a lot of our care, despite the fact that we have the historical perspective, or the fact that we can see that many of these deaths are not associated with the social determinants of health. And regardless of those social determinants of health, if you're Black, you're at a higher risk of dying. We also see that in our terminology that we use in our research, in our public health, in our public health practice, in our healthcare, we use a lot of blaming terms to put the blame back on the mother or the family rather than on the policies and procedures of the system, or even examining or thinking about the historical perspectives. So a lot of our terminology is definitely discriminatory and definitely blaming to our families. We tell them that they're non-compliant. We do not have equitable language that encourages and empowers our families to be advocates for themselves or for shared decision making. So now that I've laid the groundwork around like why justice, I want to give you an update of what we do at the Kansas Birth Equity Network and why we are the Kansas Birth Equity Network. So the Kansas Birth Equity Network was founded in 2021 through a PCORI grant to really engage diverse stakeholders around to create solutions for Black maternal, paternal, and infant health. This work was birthed out of the engagement grassroots organization of the Kansas Sisters and Brothers for Healthy Infants, which were fraternities and sororities, Black fraternities and sororities, who came together to increase the awareness of infant mortality, Black infant mortality in their community, and to highlight the impact of co-parenting. And so the Divine Nine, which is Black fraternities and sororities, came together to really increase this awareness. And from that organization, we were able to launch the Kansas Birth Equity Network. So the Divine Nine still serves as the advisory board of this network, but the Kansas Birth Equity Network was really birthed to ensure that every Black mom, dad, and infant receives quality and intentional prenatal, neonatal, and postpartum care in the state of Kansas. And how do we do that? Our vision is that every Black mom, dad, and baby celebrates the baby's first birthday, because the goal is to take care of the entire family, because life begins with mom. To take care of the entire family and to strengthen them in the way that they need that strength. So our approach to reproductive justice have been very, very centered on community. We are a community-centered network. We are largely an engaging network that engages these diverse stakeholders that are not diverse by race, but diverse by their role in the community. So it's not based on race, but what they do in the community is why they are diverse. So whether you are a parent, a grandparent, a aunt, an uncle, a niece, a nephew, a godparent, whether you're a church member or a maternal and child health organization leader, a physician, a midwife, a doula, a researcher, a community health worker, all of us are at the same table creating solutions together. And so it's about engaging the community to address the Pacific's need. It's also about training and education. So providing those resources and programs to healthcare providers and community members, and research and data collection. So as a researcher, we also conduct, under the Kansas Birth Equity Network, NIH research to look at disparities in early onset preeclampsia. And then advocacy is about promoting policies that support maternal and infant health equity. And for KBN, the Kansas Birth Equity Network, we were able to work with our community members to create two things: a definition of birth equity and a birth justice statement, a reproductive justice statement. And so our birth equity definition is shifting the blame from Black mothers and birthing people for their health outcomes to holding systems accountable, demanding policies, programs, and reparative action, acknowledging and healing historical trauma. And that means that we are no longer blaming parents for their outcomes, but we're really looking at those systems and policies that may in some way exacerbate those outcomes. And reproductive justice is supporting the right to have a healthy birthing experience for everyone. Every person that's birthing, maintaining personal body autonomy, and parent the children in safe and sustainable communities, especially for Black families. So the right to parent is overall reproductive justice in the site and the definition for this community engagement core. So who are we? We are the community. Our roots are in the community. We started with the Divine Nine, and today we are a community-centered network. We have members in both Kansas and the Kansas City metro area. So someone would tell you that that God loved Kansas so much, he created it on the Kansas side and the Missouri side. We're separated by a street. So that Kansas City metro area, we engage everyone. Also, we have diverse members in here. We're centered around Black families, but every family is invited to participate in this work. We are just simply trying to address those who are of most need. And we celebrate Black babies and families. We develop solutions. Our community engagement strategies are defined in our community engagement roadmap that was defined by our members. Why engage with the Kansas Birth Equity Network? Why is it important? It is most important, because we create a safe space to have the hard conversations. And we put the community first. So even in our research, we put the community first. Our knowledge is power. And so with knowledge, we were the first to create a birth equity curriculum that has not only been offered to our KBN members for absolutely free, and this is a curriculum that was created early on in the Kansas Birth Equity Network in collaboration with the Divine Nine, the fraternities and sororities and community members. But this education is also offered to our medical students, it's offered to our OBGYN residents, it's offered to our PQC nurses, our nurse champions across the state. And so we have offered this knowledge to everyone who is dealing with individuals that are birthing. That is the goal. And so the goal of this is to really highlight the experiences of Black families, also to highlight Black birth workers, and also to do a stop, look, and listen and think campaign. So really creating respectful maternal care. How do you provide care without stopping, looking at someone, listening to them, and thinking, how would I want to receive care? We also have equity in healthcare. So we developed a birth equity clinical scholars training program in the George Floyd era. I proposed this to our department in OBGYN and family medicine. And so this is a 2-year fellowship for those residents. And the goal of this fellowship is to teach them how to provide equitable care to Black communities. And so they spend 40 hours a year doing service at a Black-led or Black-focused maternal and child health organization, and that's service, not clinical care. They also go to the Capitol once a year as a group and participate in bipartisan policy making, which means they're meeting with legislators, they're talking, they're providing education. The goal is that they will educate our legislators who are making these very vital decisions about birthing and outcomes and insurance and healthcare in our states. And so those are the important components of this, is that physicians do not get the opportunity to work with our communities or have exposure to our communities before they go into practice. And that in some ways creates inequities. And so we aim to reduce that. And one of the reasons why we created this program was because before we started the Kansas Birth Equity Network, we did listening sessions. And our parents kept talking about not being heard, not being seen, not being listened to, not being respected, being ignored, not getting pain medicine. And so we wanted to really work within the health system in which we sit every day to change these outcomes. And the only way to change it is to start giving exposure to our healthcare providers that are going to be providing care. Yes, attendees are important, but residents are so important as we begin doula, reimbursement, and coordination of care. They are going to be our future attendees. So meeting them at this level is very important. We have research. So as a network, we have created a 5-year research agenda, and we have funded programs related to this 5-year research agenda. We also support healthcare systems in their research, which is mostly our OBGYN and family medicine department. We also do policy and advocacy as a part of this. And again, our research areas are really focused on early onset preeclampsia, group prenatal care, and mental health. So with advocacy, that is our power. We partner with 4 other organizations. We introduced a Momnibus bill in last year's legislature, which did not go anywhere, but we are still working to strategize and to redefine that. We have been able to change some things administratively. We also are working on a paid leave bill that would give every family in the state of Kansas paid leave, and particularly would be beneficial for our parents. For our network, we have what we call solidarity and solutions and information. We do not say education because you do not need an education to raise a baby, but you absolutely need information about things that are happening and awareness. So each year we have a Birth Equity Summit, and as a part of that Birth Equity Summit, we have a Birth Justice Walk. And in that, we're walking in solidarity that we support birth justice. And so we have the opportunity to come together and do so in a way that really helps us experience the work. We have celebrations because we believe as a network that our role is to affirm our communities and no longer de-emphasize them. They're not underrepresented. They're not low income. They're not undereducated communities. We don't want to highlight poverty. We want to highlight the strengths in our community and affirm those strengths and work with our community to create solutions. So each year we have a Black Maternal Health Week event that is truly focused on the top cause of Black maternal mortality, where we have participation from every race, from every gender, from every person in our state to come together and have these intentional conversations, safe conversations. We offer a keynote speech, a panel discussion. We offer free daycare from a licensed daycare provider. We offer food, and we offer prizes, and we offer vendors from every walk of life. And the goal of that is that we want vendors to come in so parents can have a one-stop shop. So we even have vendors that are from banks that allow the opening of bank accounts despite what your past history is. We have realtors come. The goal is to have everyone that our families need in one place. We also have a celebration of life every year in families. We have a Black baby photo contest each year, and we always have at least 27 participants in that. And the goal of that is to celebrate the babies living past the 365-day mark. And this started in COVID-19. So we used to have a wall of fame where we would have the parents put the name of the child and their birthday, and we would have a birthday party for the families. But given that COVID-19 hindered all of that, we now have a celebration of life online where you can enter into a Black baby photo contest, and our members decide who the winners are. And I'm so grateful for that because these babies are so cute and so lovable that I would be picking all of them. But the winner of this contest gets a prize. The mom gets a prize. Why do we give that gift, that incentive to mom? Because when mom has baby, everybody forgets to celebrate mom. And so we have stepped into that gap, and we are celebrating mom in that. So the incentive for winning this is always a mom gift. We want to make sure that we continue to celebrate and uplift mom throughout the process. And you see how cute those babies are. And so this is our team. We're growing. We have many individuals that work with us. We work with full-time employees, but also we are an education and academic institute. So we have learners. So you can see our team there, and our two new individuals are Deja and Brianna. And so we all work together to create this equity. We also, because we are a community engagement core, we have community members that are a part of our core team and leadership. And so we're working closely with the community, and anything that happens in the community, they lead it, they manage it, they keep us accountable as well. And so they're always on things. We have what we call our patient advocate leads, and we have our community engagement manager. And so we're in the community all the time. So these are contractors, but they are actually in the community doing the work. Sapphire owns a doula organization. Reverend Tony Carter is a community member that is out in the community each and every day, running our barbershop initiative, engaging patients, and on running our resource depot, where we provide resources to the community once a month, diapers to families and toiletries. Cal Ellison runs our fatherhood initiative in Wichita, and then Shalise Clay is a Missouri participant, and she also is leading a maternal health initiative, Uzazi Village, and helps us through our policies. So we have both Kansas and Missouri representation. Thank you so much for your time. I can't wait to answer your questions. I can't wait to hear the other great speakers give their talk. And again, I appreciate this opportunity to be with you virtually during these times.
Thanks so much, Dr. Smith. That was amazing. Can't wait to hear more about that. And next, Noya Woodrich is going to be speaking to us about her work. Noya.
Good morning, everyone. I apologize in advance for this coughing. I've been doing a fair amount of traveling, and I managed to pick a little something up. Thank you for the invitation to speak with you today about health disparities here in Minnesota. It is wonderful to look out at this group and see the many partners that we get to work with in public health, and think about all of the great work that we get to do here in the state of Minnesota. Let me begin by saying families of color, those in poverty, American Indian families, and children and adolescents with special health needs are the focus of the division's work, of my division's work at the Minnesota Department of Health. We know that prenatal and early life experiences in particular can greatly influence long-term health outcomes. They improve factors that influence a child's success, and all of that starts with mothers. In Minnesota, we are often ranked as one of the healthiest states in the country and one of the best states to raise a family, with strong economic indicators and quality of life. We are proud of the strength of our tribal nations, our recent immigrants, refugee communities, Latinos, people of Asian and African descent, and more. However, maternal health disparities tell a different story, one where not all families experience the same outcomes. In Black and American Indian moms are dying at a much higher rate.
Rude. But
Structural
I'm hoping
racism has
that Mom and
defined our
Bill will be
inequities
willing to watch
in maternal
Walker
mortality.
an evening
Minnesota is working to break
sure
this
they will.
cycle for women and their infants. There are several state programs that aim to improve maternal health and disparities within Minnesota through a public health approach. Our work strives to focus on prevention and considers social determinants of health to achieve better outcomes for families. The first program I will talk about is the Maternal Mortality Review Committee. A mortality review committee is the highest standard for state-based data on maternal mortality. Our committee is multidisciplinary. It includes many specialties and perspectives to gain understanding of what happened from many different lenses. It includes the voice of our communities, especially from communities most impacted by the disparities in our state. The committee also looks at where systems do and do not connect to help expose gaps, especially those related to socioeconomic status or a mother's ability to meet basic needs of food, housing, and safety. The committee examines all Minnesota maternal deaths to identify and reduce preventable contributors and causes, including effects of access to care, standardization of care, discrimination, racism, and mental health conditions and substance use disorder. But of course, all of these issues are connected. For example, the lack of access to care is especially true for those with substance use disorder. And those who struggle with substance use disorder are also more likely to experience discrimination. The examination by the review committee helps guide recommendations to influence state guidelines and policies and ultimately reduce preventable perinatal deaths in Minnesota. The Maternal Mortality Review is an ongoing, anonymous, and confidential process of data collection, analysis, interpretation, and action. It is a systemic process guided by policies, statutes, rules. But most importantly, this review is intended to use data collection to drive prevention activities. The Maternal Mortality Review is not a mechanism for assigning blame or responsibility for any specific death. It is not a research study or a peer review or an institutional review. It is also not a substitute for existing mortality or morbidity inquiries. The review process involves five key steps. First, we identify the deaths of Minnesota residents. We select and collect and review records about the death. We develop an abstract and conduct interviews, which involves writing a de-identifiable story about the death. We review that story about the death. The committee makes decisions on several key questions, specifically, if she had not been pregnant, would she have died? And finally, the committee disseminates the data for action through recommendations for changes. By comprehensively reviewing every death, making recommendations for action, and acting on those recommendations, the work of maternal mortality review committees can eliminate preventable pregnancy-related deaths, can reduce maternal morbidities, and can improve population health for women of reproductive age. This particular review process is funded currently by a 5-year grant from the CDC with some additional state dollars put in. These dollars are ultimately invested to help us better understand what and where the gaps and concerns are, so clearer and more actionable recommendations can be made. No one wants pregnant and postpartum mothers to die, Pregnancy-related deaths are only the most extreme of bad outcomes. They are the tip of the iceberg of what is happening to Minnesota mothers. Through the understanding that happens in the worst cases, the committee makes recommendations that can impact all families. As a reminder, pregnancy-associated death is a death during pregnancy or within 1 year of the end of pregnancy, irrespective of cause. Before we dig into the data, it is important to remember that each of these deaths was a person who was loved. It was a sister, a wife, someone's friend, and a mother. And in many cases, they left behind a new baby who will not grow up knowing their mother. Maternal deaths leave a ripple effect on the communities and families where the individual lived. The committee reviewed 75 pregnancy-associated deaths between 2017 and 2019. While Black mothers and American Indian mothers are a small portion of the birthing population, just 13% and 2% respectively, they are disproportionately represented among the pregnancy-associated deaths. Black mothers make up more than 26% of the deaths, and American Indian mothers make up 12% of the deaths. In 2019, 74% of pregnancy-associated deaths were of metro-based residents. Over the 3-year span of 2017 to 2019, 60% of pregnancy-associated deaths were residents of the metro. Though the metro region experiences more deaths, several greater Minnesota regions have a higher proportion of deaths as compared to the proportion of births. From 2017 to 2019, nearly 67% of pregnancy-associated deaths occurred between 43 and 365 days postpartum. The pregnancy-associated mortality ratio was 37.1 deaths per 100,000 live births. The state's pregnancy-related mortality ratio was 8.9 deaths per 100,000 live births. For comparison, the national pregnancy-related mortality ratio in 2019 was 17.6 pregnancy-related deaths per 100,000 births. The top 5 leading causes of all maternal deaths between 2017 and 2019 were injury, including suicides and homicides, mental health conditions, including overdose deaths, cancer, and infection. It is important to note that at the time these cases were reviewed, CDC recommendation was to code overdose deaths as mental health conditions if there was a substance use disorder. Based on these findings, the Minnesota Maternal Mortality Review Committee has made the following recommendations. Support statewide improvements for women who have substance use disorders or mental health conditions, including adequate identification of substance use and mental health conditions for women, referral to behavioral health services and support groups, and increased funding to expand treatment and access to treatment throughout the state. Develop standardization of a referral network within systems and regions to refer women to locations for appropriate level of care and to decrease delay in needed diagnostics, interventions, or elevation of care. Improve the postpartum period by assuring that women have access to care team no later than 3 weeks postpartum. Address bias in systems perpetuating disparities for women. Acknowledge historical trauma and racism and the impacts of that on women. Fund community-led networks and support systems to provide culturally informed care to women's needs. Listen and support women. Listen to concerns, provide a network of support during and after the postpartum period. Additional recommendations from the 2019 reviewed pregnancy-associated deaths focused on improving access to and availability of services throughout the pregnancy and postpartum stages. These additional recommendations also emphasize the critical need for seamless care for individuals with a substance use condition and/or mental health condition throughout this pivotal period in their lives. Another maternal health program in Minnesota is the Pregnancy Risk Assessment Monitoring System, also known as PRAMS. Minnesota PRAMS is a surveillance project between MDH and the CDC to collect information on maternal behaviors and experiences before, during, and shortly after a woman's pregnancy. Minnesota is one of 47 states across the country that participates in this project, and we have been doing so since 2002. PRAMS provides data on mothers and babies that is not available from other sources. The goal of PRAMS is to improve the health of mothers and babies in Minnesota by reducing the risk of adverse birth outcomes like low birth weight, preterm birth, as well as infant and maternal morbidity and mortality. Let me share a bit of what we know now thanks to our PRAMS efforts. Mental health conditions during pregnancy and in the postpartum period are generally underdiagnosed, not treated, and underreported. Postpartum depression is a common but serious mood disorder that affects mothers after their baby is born. Mothers may experience profound feelings of sadness, anxiety, and fatigue that can hinder their ability to successfully engage in everyday responsibilities, such as self-care or caregiving of others. 32% of Minnesota's mothers in 2022 reported that they needed mental health services after their baby was born. The highest need was among American Indian and U.S. Black-born mothers. Though U.S.-born Black and American Indian mothers reported the highest need for mental health services, they were less likely to receive those services compared to white mothers in the state. In Minnesota overall, the broader population, or all groups together, experience less racial or ethnic discrimination. However, there are stark differences in experiences between different race or ethnic groups, making it clear that US-born Black and American Indian mothers face more perceived discrimination compared to the broader Minnesota population. 33% of US-born Black mothers, 24% of Hispanic mothers, and 23% of American Indian mothers reported being emotionally upset because of racial discrimination 12 months before their baby was born. Of the mothers who reported feeling upset because of racial discrimination before a baby was born, 29% of those experienced postpartum depression. And 22% reported not receiving postpartum checkup because of how they were treated. The percentage of low-income respondents who self-reported postpartum depression was also 2 times higher compared to high-income residents. Thankfully, Minnesota's new Dignity in Pregnancy and Childbirth Act was passed in 2023 to help reverse this trend. Minnesota's legislation requires hospitals with obstetric care and birth centers to develop or access a continuing education curriculum on anti-racism training and implicit bias. Minnesota is only one of a few states implementing this training statewide. The training, developed by the University of Minnesota Center for Anti-Racism Research for Health Equity, in partnership with the Minnesota Department of Health, courses focus on Black and American Indian birthing people. Race and income are just some of the social determinants of health that PRAMS explores to better understand experiences of Minnesota mothers. Incarceration impacts many families. In 22, 18% of American Indian mothers and 8% of US-born Black mothers reported either they or their husband or partner went to jail, compared to 1% of the overall population. Food insecurity is also a growing trend. 1 in 11, or about 500,000 Minnesotans, face hunger, and 1 in 7, or about 180,000 children, face hunger. Households with children and people of color experience food insecurity at a significantly higher rate than the national average. And it's worse for households with income below the poverty line, single mothers, and Black and Hispanic households. 34% of Black and 22% of American Indians report that the food they bought did not last and they did not have money to get more. Transportation is another social determinant of health. In 2022, 24% of Black and 25% of American Indian parents reported that lack of reliable transportation kept them from medical appointments, meetings, work, or getting things they needed for daily living. Low income is another social determinant. In 2022, 47% of Black parents and 27% of American Indian parents reported that they were unable to pay rent, mortgage, and bills during the last 12 months, compared to 10% of mothers statewide. Additionally, 26% of Hispanic women faced financial difficulties. The final social determinant I would like to note is homelessness. In 2022, 11% of Black and 12% of American Indian parents reported that they were homeless or had to sleep outside, in a car, or in a shelter. Some additional areas of concern that impact maternal health that I will go through include substance use disorder, opioid use, and counties without a birthing hospital. The rate of substance use disorder at time of delivery hospitalization in Minnesota decreased by 11.5% from 2019 to 2023. However, the change in substance use disorder rate varied by state community health, by SHAC, the State Health Services Advisory Committee region, with the South Central and Southeast regions seeing increases over this same 5-year time period. Individuals who had a substance use disorder documented at time of delivery hospitalization are more than 3 times likely to have at least one severe maternal morbidity. Maternal morbidity is any short or long-term health problem that results from being pregnant or giving birth. The rate of opioid use disorder at time of delivery hospitalization in Minnesota from 2019 to 2023 was 61.4 per 10,000. The northern regions in Minnesota had the highest rates of opioid use disorder compared to the rest of the state. More support is needed to address substance use disorders and mental health services, such as expanding virtual visit capabilities and physical facilities, increasing the number of waivered providers, improving access to treatment, and implementing harm reduction and overdose prevention practices statewide. Access. Access to care during pregnancy and delivery is not consistent across the state of Minnesota. There are 36 out of Minnesota's 87 counties that do not have a birthing hospital. This means some moms have to travel long distances, up to 2 hours or more, to receive care during birth. Hospital closures and provider shortages lead to unequal access to maternity care in rural areas and among communities of color. The farther the distance a pregnant person must travel to receive maternity care, the greater the risk of receiving inadequate prenatal care. This results in higher rates of preterm birth, increased low birth weights, and adverse infant outcomes, including stillborn and neonatal intensive care admission. Many pregnant individuals seek support from doulas and/or midwives specifically to help bridge this gap. They provide critical continuous support, and they improve outcomes for the whole family. Data from Minnesota birth records show that babies of mothers who do not receive prenatal care are 3 times more likely to be born low birth weight and 5 times more likely to die than those whose mothers who did get prenatal care. We recognize that systemic racism is a root cause for creating and continuing to create barriers to accessing quality care before, during, and after pregnancy and delivery. To support the access issue, the Minnesota Department of Health has hired staff to support the expansion of perinatal care, including doula and midwifery services and maternal health services. We've created a new free searchable list of doulas on Help Me Connect, which is an online resource platform. And we are working with partners to increase reimbursement amounts for doulas to help further remove difficulties in accessing prenatal care. When we think about maternal health, we also must appreciate the interconnectedness of the mother's health to the health of the infant. Many of the same health disparities mothers face are also impacting infants. Minnesota's infant mortality rate is 2 times greater among infants born to Black and American Indian parents than non-Hispanic white parents. Prematurity or birth before 37 weeks is the leading cause of infant mortality in Minnesota. Black, American Indian, and multiracial parents have the highest rates of preterm births. Access to prenatal care not only provides significant benefits to the pregnant person, but it also confers a myriad of benefits for the infant. Additional public health programs that support infants, pregnant women, and young families include our family home visiting program, child and teen checkups, and supplemental nutrition programs that are known as WIC. I want to end by sharing that health is determined not just by access to high quality health care, but also by healthy social, economic, and environmental conditions. Black and American Indian women in Minnesota face significantly higher risks of maternal mortality, highlighting deep inequities in healthcare access and quality. If we want Minnesota to truly be the best place to raise a family, we must address these disparities and ensure that every mother, baby, child, and adolescent has an equal chance at a healthy start. Thank you.
Thank you so much, Noya. Now we'll have Dr. Asha Hassan step forward.
Good morning, everyone. My name is Asha Hassan, and I'm going to be talking about this from a little bit of an earlier perspective, thinking about family planning access as a health equity imperative. I'll provide some definitions and grounding on abortion policy in the US and in Minnesota, explain historical and contemporary narratives on abortion through an anti-racism lens, and describe why abortion access is crucial to the health equity dialogue. I want to kind of also share that some of the frameworks that I use to inform this work includes the Reproductive Justice framework, which is the right to have a child, not to have a child, and to parent in safe and sustainable communities, all linked with bodily autonomy, and that racism is a fundamental cause of disease and a driver of racial health inequities. So some other definitions, we oftentimes use the word family planning and birth control interchangeably, but family planning is defined as the ability of individuals and couples to anticipate and attain their desired number of children and the spacing and timing of their births. Family planning emerges as a critique and a substitute for the phrase birth control. Until today, we still use those words interchangeably, but when we use the word birth control, we don't really say who has control, who has agency, and family planning really allows us to recenter that. You're probably wondering why I have this picture of Malcolm X here. Kind of random. Well, that's because in a 1962 interview, Malcolm X voiced his preference for the term family planning in lieu of birth control. He felt that the term family planning gave room for self-determination, another word for self-determination, autonomy, and that was something that Black communities had to be concerned about. When we're talking about family planning, for the most part, we are talking about abortion and contraception. And today, when we're talking about abortion, we usually mean medication abortion or procedural abortion. I use these terms loosely just because there are social, legal, and clinical perspectives that use these terms a little bit differently. So I won't specifically define abortion and contraception. This has obviously been, family planning has been a huge part of American policy for a very long time. And here are some examples of court cases focused on access regarding contraception and abortion policy. I won't go into all of these, but just to kind of understand the length of time, including currently under what Medina versus Planned Parenthood, which was court arguments listened to earlier this week, has consistently been a part of the American political dialogue. It's important to understand that legal and clinical guidelines around abortion oftentimes converge. And if you think about some of this data that I've laid out here over the course of the gestational age and duration, it kind of is limiting for people, especially thinking about some of the bans that we're seeing across the country. For an example, a 6-week ban. Many providers don't don't provide abortions before 6 weeks gestation. So if somebody finds out that they're pregnant, usually as early as 4 weeks, somebody has a missed period, that's 4 weeks, then they might call an abortion clinic and ask for support, and it might take them 2 weeks to get an appointment. So it kind of already limits them in their ability and to be able to access that type of a care. And that doesn't even give room for somebody to think through what their options are and consider talking to their community members, talking to their families. And that's just kind of useful to understand when we think about where the legal and the clinical decisions converge. Another thing to understand is that there is this idea around exceptionalism for abortion. So we don't go to our primary care providers for abortion care. Is one example of how that works. It's defined as the signaling out of abortion from other areas of medicine on the grounds that it is special, different, or more complex or risky than is empirically justified. We know medication abortion is safer than Tylenol. So it's not founded in the research and in the literature that it is any sort of special type of healthcare. And yet it is siloed and marginalized in the American healthcare system. So why is abortion policy relevant to health equity? I think it's very useful to understand the history of abortion in this country in order to understand that it has always had to do with race and racism, and that structural racism plays a primary role in our decision-making around abortion policy. So I'm going to give a brief history of the US through the lens of abortion and racism. Long before settler colonialism, Indigenous peoples utilized the knowledge of medicinal plants through every stage of reproductive health care, including abortion. Ph.D. candidate Abaki Bak at the University of Minnesota School of Public Health writes, abortion has long been seen as a religious right, and that Indigenous plant knowledge is still passed down from generation to generation and is learned after years of formal training by practicing proper cultural protocols. We first begin to see suppression of abortion on this land during slavery. Slave owners would enact policies that undermined a mother's well-being in favor of her potential child, and manipulate women's decisions about childbearing through coercion and incentives. For an example, lighter workloads as a reward for having more children. A thorough examination of medical diaries and personal accounts from this time reveals that certain white plantation owners and doctors were convinced that enslaved Black women possessed knowledge of contraceptives and the process by which one could terminate early gestation pregnancies. All the evidence points to the possibility that enslaved Black women leveraged contraception and abortion as a form of resistance to slavery. In the later half of the 19th century, we see the advent of the first abortion bans. Motivated by a desire to drive out midwives from the healthcare market and monopolize the market on childbirth, the newly formed American Medical Association initiated a national anti-abortion campaign. These early gynecologists lobbied state legislatures to ban abortion and the practitioners who provided that care. midwives, a multiracial, woman-led workforce. And they did this by leveraging a growing demographic concern about racial replacement, namely a deep fear that with the onset of the African-American migration and an increase in immigration in of Southern and Eastern European middle-class Anglo-Saxon women would be outpaced in producing children, leading to an eventual minoritization of white Protestants. Essentially, these first abortion bans were meant to coerce middle and upper-class white women from seeking abortions and limit their reproductive decision-making. The AMA's efforts were effective and swift, and by the end of Reconstruction, induced abortion was illegal in most of the United States. Another foundational policy story about race and abortion is about the formation of the modern-day anti-abortion movement. In the early 1970s, the desegregation of schools and the Roe v. Wade decision became important touchstones in the formation of the modern conservative movement. While the desegregation issue directly affected conservative white voters in the South, Roe v. Wade provided a new issue that could unite a broader coalition of conservative and religious voters. The combination of these two issues helped to shift the political landscape and cement the alignment of evangelical Christians within the Republican Party. By focusing on issues like abortion and family values, the Republican Party, with the help of organizations like the Moral Majority, were able to build a powerful voting bloc that would dominate American politics for decades. I share this history through this lens because it tells us so much about how race and racism have been a part of the story the whole time, and therefore worthy of research exploration in the contemporary. Even today, we see scripts and narratives that are racialized about abortion seekers. An example of this is the idea of the perfect victim of the Dobbs decision, the Supreme Court decision that reversed the previously held right to an abortion. These perfect victims are frequently perceived to be white, blonde, married, middle-class women who are seeking to grow their families and expand their families through IVF or the termination of a wanted but non-viable pregnancy. They are championed by civil rights organizations that are discussed sympathetically by anti-abortion advocates and policymakers. This is very different from the emerging stories of Black women who have been criminalized, like Brittany Watts for miscarrying at home, whose story required a grassroots push to generate national attention. Or Amber Thurman and Candy Miller, both Georgia women whose deaths happened as a direct consequence of the Dobbs decision. Their stories just late last year coming to light 2 years after their deaths. Clearly, the story of family planning, historically and currently, is one of stratified racial reproduction, making it an ideal lens through which to examine race, racism, and racialization in health. So if you look at this map, what do you see? Anyone brave? Yeah. The South is very red. And we really see that as where there are higher rates of some of these stories, these narratives that we saw on the previous page, as well as just like large populations of reproductive age women and reproductive age folks who are more likely to be racialized. So I want to point out the statistic that I often get asked about. It's from the Guttmacher Institute, 2008. In the United States, the abortion rate for Black women is almost 5 times that for white women. I'll let everybody sit with that for a second. So I think as a reproductive justice informed scholar, I can't think of this as necessarily an inequity, but maybe a disparity that is caused by inequities. Structural racism and poverty are interwoven in the American fabric. And we can see, thinking through like a life course lens, how racial inequities in health education and healthcare access, being denied an abortion, and adverse birth outcomes, racial inequities in the post-period, including criminalization and social stigma, are all things that happen at different points, and that seeing things through the silo of just the lens of what is happening during somebody's pregnancy is not necessarily a useful lens to understand structural racism's life course effect on abortion access, or abortion access's life course effect. So some examples of some racial inequities that we are seeing post-Dobbs, I want to point out. So one is a paper from 2022 that after Dobbs in states with abortion bans, travel times increased on average over 4 hours, and that Black women saw the greatest increases, with 15% having to drive 1 hour before Dobbs to 40% greater after. And some projections around what this would mean for maternal mortality, that banning abortion nationwide would lead to a 21% increase in the number of pregnancy-related deaths overall and a 33% increase among Black women. So what about Minnesota? So there are 9 abortion-providing clinics in Minnesota, and we have seen a significant change. I apologize for the slides. It looks like they came out a little bit wonky. Is that we can see that there have been several things that have been rolled back, including state-mandated counseling, a 24-hour wait period, a physician-only requirement, and parental notification laws. Those have all been removed over the last few years. The one thing that is kind of left is abortion surveillance. So till today, if a provider is providing an abortion, they have to fill out a form, they send it to the health department, and then we get statistics on that at the end of the year. That's pretty normal for a lot of different complex health-related issues, but for the most part, because it is such a safe procedure, this has kind of been considered for some providers and abortion-providing institutions as extremely burdensome, and as a way to surveil them, especially in the social context where providers and patients are concerned about criminalization. This was mentioned a little bit earlier, but the Minnesota paradox is very useful in our understanding here. It's important to note that even though racial inequities are pervasive across the US and the globe, Minnesota uniquely has very deep racial inequities. And what Dr. Samuel Myers, a UMN professor of public policy, has coined the Minnesota paradox. This refers to the simultaneous existence of Minnesota as the best state to live in and the worst state for people racialized as Black to live in. Dr. Myers says that understanding the Minnesota paradox is essential for recognizing how deeply rooted historical and structural inequities shape residents' lives. So here are some examples in the ways that shows up, the racial gaps show up. So in kind of line with that, I do have some data on structural racism and abortion here in Minnesota, thinking about delays to care. And what we see is that there's about 0.87 days longer wait time for Black abortion patients compared to their white counterparts, and that structural racism plays a role in this. So what we can really think about here is what happens before the clinic. So thinking about access to transportation, thinking about access to like prenatal care or care before care before they're able to contraceptive care before they're able to reach the clinic, and also thinking about some of the pieces around sex education disparities, and that all kind of playing a role in what people have access to and being able to get their appointments when they want to get their appointments. I'd also like to point out that this data comes from a very privileged group of people who did have access to their abortions and not folks that didn't have access to their abortions. So we could potentially be seeing like larger inequities here as far as access. So to close out, even though the Dobbs decision eliminated federal protections for abortion rights, the decision also provides an opportunity to establish and codify federal policies that guarantee bodily autonomy and access abortion care. These policies, along with access to full spectrum reproductive health care services and insurance coverage, are key to advancing reproductive freedom and autonomy. Some recommendations is to trust individuals as experts of their own bodies, reframe abortion access as fundamentally an equity issue, and to call out structural racism as a cause of racial inequities. Racial inequities do not exist in a vacuum. And that's it. Thank you so much.
That was wonderful, all three of you. So now we're going to move into the Q&A. And we'll get Dr. Smith back up so we can see you on the screen. And I believe we're going to have questions from the room. So somebody will be going around with a microphone, so please get ready with your questions. And then we also have some questions, I think, that are going to be coming through on the Google form. Is that right, that some of these will be popping up down here, the Google form ones live? Okay. So then folks who are Zooming in can also please definitely put in your questions and we'll be reading those off. So I'd like to invite the two people who are present, Asha and Noya, to come and be there for our panel. And Dr. Smith, we see you, and we're very excited to have all three of you here. So why don't we just start with a question to the group, and I'll just pitch it, and you guys get ready with your questions. Okay, so have those ready. So just a big picture. How have you all seen the landscape of reproductive health and justice change in the last 10 years, the last 2 years, nationally, in your state? What are the tea leaves telling you? Where are we at right now? And where have we come from? Like, are you seeing some positive trends, only negative? What's your feeling about reproductive justice issues and their trends?
Oh, there we go. I think even in talking about reproductive justice is pretty new. I mean, reproductive justice is a term that was coined in 1994, a month before I was born. So for context of how long that's existed in the lexicon, and yet it's in the contemporary conversations we've had around reproductive health and rights, it's really just been the last 6 or 7 years that's kind of been considered the primary framework in which researchers and policymakers are understanding the issues around family planning and birthing and postnatal care. So there's that piece. I also think we're seeing a lot of trends in medicalization and demedicalization. So we went through a long phase of having more and more interventions around birthing, more and more interventions around contraceptive care, and we're somewhat taking some of those pieces away and understanding that there is value for some people to have more agency when there's less medical intervention. So I think we're kind of moving in that direction and understanding that that is also potentially a lens to which to reduce inequities.
Here in Minnesota, since the early 70s, there's been this source of funding, state dollars, family planning special project grants. That's administered by my division at the Minnesota Department of Health. In 2023 legislative session, there were changes made to that statute for the very first time since it was created in the early 70s. So it went many, many years without having any changes to the statute, which put some restrictions on how the funding could be used, who could receive the funding, and how the funding was dispersed across the state of Minnesota. So a couple things. One, and I think most significant, is the amount of money made available for that grant program doubled in 2023. So prior to that, we had about $6 million available a year to grant out for, we now call it the Sexual Reproductive Health Grant Program. And that doubled to close to 13 million in 2023. So that was a really huge win for us and our ability to support work across the state of Minnesota. couple other changes about the statute is who could get the money. Prior to 2023, tribes were not allowed to apply for the money. They were not written in as an eligible applicant. We added that in 2023. Now, no tribes applied. I think that says a lot about how family planning has been implemented in tribal communities. My goal and plan is that we have some conversations with our tribal communities about what it means and how they might use it for their defined purposes. And hopefully the next time that we have a competitive process, we will get some tribes to apply. It also allowed non-medical facilities to be able to apply for the dollars. So it kind of expanded the number and type of organizations that were eligible for the money. So I do think that that's I do think that that is significant. And then to a point that you made in your presentation, the surveillance, true, it still exists, but it's not surveilling all that it used to surveil. And there was an attempt in 2023 to just do away with the surveillance, but some of the legislators wanted to hang on to a few pieces. So there is some surveillance occurring yet, but not as much as before.
Thank you guys for that insight. And I just want to say that while reproductive justice was coined in 1994, I was born before 1994. But that the overall, when you think about reproductive justice, it is the right to have children, the right to not have children, the right to nurture your children in a safe environment, right? So this work has been happening for centuries, which is why we had a law on the books that said you had the right to bodily autonomy, right? And in that change, before that change, we saw so many political gains on women's reproductive rights. So as far as legislators have always attacked reproductive rights, right? Our right to own our own bodies, to have children or not have children, or to provide safety in children. It's not just about the realities of abortion or not, but if I don't have health insurance, that is not the right to provide a safe and nurturing environment for my child. So we have to think beyond the abortion, no abortion in this, and just how does these policies impact families and family stability? And when we think about Black people, we think about the dismantling of Black families, right? And the fact that Black families are still trying to rebuild from historical perspectives of who we were identified as or not identified as, right? And so getting to reproductive justice is a different path for Black families than it is for other families. The other thing is, I live in Kansas, and we do have the right to abortion that was voted here on the ballot. And there was a major upbringing of movement for people to really support abortions. But in order for that to happen, we had to have a lot of education, because there was a major belief that people were, aborting 8 months at 8 months of pregnancy. Like, there's a lot of misleading information out there. And for that, we had to really do a lot of grassroots work to do that. But even in an abortion-free state, our legislators have passed $2.5 million for anti-abortion work, right? So even in the right, there's still a lot of money behind not having the right. And so, while the work has progressed and we now have a better understanding of it, and we've made some movement, it seems as though it is the replication of the United States. We move forward 2 steps, we move back 5 steps. And so there is so much more work to be done around reproductive justice, because now if you ask the average person what reproductive justice is, they're going to say whether or not you can have an abortion. They're not thinking about the whole person or the whole family, or that life begins with the mother. And so we have to take care of mothers before they get pregnant. We have to give them the ability to have quality care and all of those things. And so I think that while history has, been progressive, and also, we have taken a lot of back steps in history. Where we are now in political rights is even worse than where we were even at the end of this decision, right? Because now there is more fear. Now there is a shortage of physicians. We have a 30% cut in OBGYNs, and we have maternal health deserts. We have rural hospitals that are closing. There are so many threats now to reproductive justice, and we're only looking at it. Even the Black campaigns and policies that are being put in place. And we're only looking at it from the abortion standpoint, but we really have to look at it from the whole person. If people aren't employed, how do they have the right to nurture their child in a safe and healthy environment? Like, there are so many factors. So I think that the first thing we have to do is look at it from a whole person. The second thing is, don't think that we've made progression when the progression is being threatened right in front of our eyes.
If you have questions, just raise your hand and we'll bring the microphone to you.
I just want to add one thing to that, because it brought up something for me. Fear, and that's something I hear more and more than I've ever heard before, the fear of criminalization, not just for people that are seeking abortion care, but also for people who want to have, healthy pregnancies and are concerned about what happens if I miscarry, like what do I do, where do I go? And we're hearing more and more of these high profile stories of people being prosecuted or persecuted for that, needing to travel across state lines for care when they didn't have to otherwise, and potentially having to deal with policing and violence in that capacity. So hearing more and more about criminalization in a way that I have not heard before.
Another question is, I think there's students in the room, and we're all learners. So what advice do you have for those early in their career, or early to this field, especially at this moment, in terms of getting involved in the work, different opportunities and ways to dovetail? I think we're hearing a lot about community action initiatives like KBEN. There's academics here, there's community members here. What are your thoughts about this moment and involvement of new people in this field? Is this something you can even foresee right now?
I think I'd normally be a little bit more helpful and hopeful than I am. If you've paid attention to the news at all, it's a rough week at Minnesota Department of Health. But I came earlier this week. I was in Phoenix, gathered with a group of Native women from across the country, talking about these very issues, maternal and infant health. And there were two women there who had to take vacation and lie to their place of employment about where they were, because they came from states where the word equity is not allowed any longer, where talk about inequities and disparities and equality and racism is not allowed. And the one person was very young, early in her career, first job. She was terrified that she would be found out, that where she was and what she was talking about. And so I was reminded of a couple things. One, I'm grateful I'm in Minnesota. It might be tough this week, and it might be tough for weeks to come, but at least I can still say the word equity. And at least I can still do equity work, and I can try to embed things and people into our system that can help do that work. I'm also grateful that I'm at the tail end of my career and not at the beginning of my career. It does give you a bit of freedom, right? Like I will push the boundaries because I have less to lose. than someone who's at the beginning of their career. Could I, right at this moment in time, go find another job in public health? Maybe not. I could find another job though, right? So I think there's some freedom in that. I think if you are starting out in this field right now, good for you. I just think prepare for some temporary flexibility, like just prepare to be flexible for a while. The field of public health is in flux. We became popular in some ways during COVID, and then we quickly lost that popularity. And people are now being given the right to hate public health and dismantle public health. And so we need to really, we need to continue to stand by public health. And I'm not, like you heard in my biography, I'm a social worker. I'm not even public health, really. I've worked in public health for many years. But we need to stand by it, and you need, as a young person, like we have students that work for us. And I think just continue to find those places and spaces where you can work on your passions and the things that you really care about. I am sorry to say that might not be directly in the public health field immediately. But go find your place, go find your space. We do have coalitions like Kansas has. There's a lot of good work going on in this space in Minnesota. Find those places and spaces and find people that you can befriend and be friendly with and get in this work together.
You want me
From
to?
a,
Oh.
go ahead. Go ahead.
Thank you. I apologize though. So I'm always reminded in these times that trouble don't last always. If you look at history, this is not our first time being here, and this may not be our last time. But you, as a student, should focus more on reimagining public health and public health practice in a ways that do address inequities. I think that it is sad that there's been so many changes in our public health field and it is under so many attacks. But in the reality of things, the system hasn't worked well for everyone. So this is a time where we could reimagine a system that works for each and every one of us, and does address inequities. No matter what they call it, the problem is still the problem, right? So whether we call it DEI or inequities or representation, it's still the problem. And I think that you have to stay focused. Don't get so involved in the chaos that you are not prepared to build the systems that we need, because the students, the new learners, are going to be a part of rebuilding this system that is being dismantled in front of our own eyes. And so, what do you see? And how can you do that? Like, you are called to a higher place than us because we came into an existing system and we've been bucking against this system since we came into it, right? Trying to get this system to be equitable, trying to get this system to be fair, trying to get this system to stop discrimination. But you guys are going to be able to build a new system. And so stay focused on that, building a new system, find your path, whatever that path is. I always tell my community members, everybody's not going to run for office. Everybody's not going to lead an organization, but what is your path? And whatever that path is, stay focused in that and know that you are an important part of the progress, regardless of what your path is. But as a learner, you have to know that this is just how politics work. But in this time, it is also a time to educate our community on how politics work, because a lot of people that voted did not know what the president could do, right? They didn't know what Congress did. They don't know what, they don't know what they don't know. And so it's an important time to build a village, not a community, but a village that supports each other regardless of race, regardless of gender, regardless of age, regardless of income. How do we begin to build those villages of support and then reimagine public health in the way that it does dismantle inequities? It does dismantle discrimination. It does represent each and every one of us at every stage of our lives. Thank you.
Yeah, from a research perspective, a lot of, there's lots of parts of research topics that have been never funded by the federal government or have been prioritized. I think gun violence is a great example of that. Up until recently, abortion-related research was not funded by the federal government. It had a small stint during the Biden administration, and that's probably gone. So I think there's so many more questions. I feel like there's more questions now than there's ever been from a purely, is there work? Yes, there is work. Is there work that is funded is the harder question. And I'll say for, abortion and family planning related research, for the most part, that work has been privately funded and supported through, smaller organizations, foundations, private donors. And those networks still exist. I plan on still doing this research in this era, regardless of what the federal government is doing around funding. So I do think there's lots of questions to ask. I don't think we should be fully pessimistic that this work isn't going to get done. And there's a lot of value in bearing witness. I mean, I'm a health services researcher, so I would like policy change to come out of my research. That would be great. But sometimes this isn't necessarily the moment where that policy change happens. There's still value in being able to understand what's happening and what the changes are. We're still trying to understand what happened in COVID, right? And the Dobbs decision was only 2.5 years ago. Still trying to understand how that's impacting families and decision-making around reproductive health care and family formation. So there's lots of questions. There's local state questions, what happened with the changes around policy that was mentioned earlier in 2022, and how does that impact how people are experiencing their care? We've exceeded expansions in telehealth. What does that mean for equity? There's so AI, so many questions. And I think there are inherently going to be solutions to figuring out how to continue doing this work even during a more difficult time.
I just want to ask out to those that are helping with Zoom. I'm seeing some chats, but I can't see them on my screen. So if anyone wants to share out what others are talking about there, I want to make sure those that are on Zoom are able to have their thoughts heard as well. One online question that I got here is, and I don't exactly know, maybe the asker can also clarify a little bit, but the question is about outdated practices in reproductive care that need attention. I'm not really sure what that means. Maybe they can clarify that. And also, what insights do you have regarding the increasing prevalence of digitized education in reproductive health? Again, I'm not as familiar with that, but that was a couple questions that came from the Google form. Any outdated practices or trends that still require attention? Not sure what that is really about, but that was a question.
I don't know specifically what they might be talking about either, but that does remind me of another change in the statute that was made in 2023 here related to the sexual reproductive health funding that we have in Minnesota. We added a phrase that would reflect changing best practices. So something that was considered a best practice in sexual reproductive health in the 90s might not be considered so anymore. And so the funding, there's a phrase that directs how the funding and what the funding is given out for that reflects that change in best practices. So I think that that's, I don't know that that gets at any specific issue this person might be asking about, but I think we do try to reflect that we know there's changes in best practices, that something that was promoted in the 90s may not be the best avenue any longer.
Now, I agree with that. I think there are, changes in policies that are happening. If they're talking about public health practice, public health does have some ancient practices, as well as, when we look at our clinical care, it's usual care that was defined centuries ago, right? So there are some practices that definitely are outdated and need to be updated. But the realities of public health practice is provided to the population. And so there are populations that do not have advancement in technology, right? They do not have the necessary things for us to make these changes to our practices. We have to meet people where they are. And so while they may be outdated in some communities, they're not outdated in others. For example, rural communities don't have access to internet and telemedicine and all the things that we have in urban communities, right? There is major need, policy change, and resources that need to be available in those communities. For clinical practice, I think a lot of researchers have been saying for years, like usual care is not intentional care for the individual, right? Care often has to go beyond usual care, and oftentimes that is where inequities exist because we get to decide who gets additional care and who doesn't, right? Who gets usual care. And if we do usual care, we can check the box and say, sorry that this patient had this issue, but we provided them usual care. I think that is, a thing to think about when you think about the ancient use for digital education. Digital education has been in existence for a while. We at health systems have been doing telemedicine, teleeducation, all of these things. I know COVID-19 was the upbringing of that, and AI is new, but these things have been in place for a while. And I will say that there are some positive impacts of digital education. There are some negative impacts. Like if those who have access to AI will really learn the things needed to keep things going. So we have to still have people turn off their televisions, read a book. We still need people watching the news. We still need people reading publications. We need people writing publications. We can't totally depend on digital technology, but we need to know that it has been here for a while. There's an increase in using it, but it's been present. And we have to only rely on it as a resource and not as the source of information. Thank you.
Yeah, I'm a little wary of the over-reliance of, digital tools. I mean, I think telemedicine and telehealth are incredibly important tools that we have access to now. But I mean, looking at some of the data in the family planning space, the people who are accessing that are a little bit older for reproductive age. So maybe people who are in their late 20s or in their early 30s. They're more likely to be white. They're more likely to be have private insurance. So it's potentially reproducing further inequities. So making sure that we are still providing those tools for people to be able to access care and services in person is vital.
A question is here. Could someone bring the microphone?
Full disclosure, this is now a fully formed question. Hi, can you hear, is this on? Okay, cool. First off, thank you so much to the panelists. This has been so great and so lovely to have the opportunity to come in person, so thank you. Okay, my question, I work for a nonprofit research firm, so we are definitely at the whim of all these cuts. currently looking for a job just to keep my options open. I'm curious for those who have a federal contract or a grant, if you have any optimism for what RFK might bring about with his, whatever he proposes, if there's any, sorry, I'm nervous, if there's any, optimism in like opportunities that he could fund, create grants, create contracts that could potentially fund your work and what that could mean for you. Your silence says it all.
Yeah, because I'm online, I can kind of jump in, but it's hard for me to think of someone who has a different view of public health as someone who will fund public health or to be optimistic about it. I'm not optimistic about what he may fund. So anything that he does will catch me, I'll be surprised about it. I want to be surprised. I want to be pleasantly surprised in this. I am optimistic in the fact that there will be an uprising of foundations and other funding that we will leverage. Also, collaborations that we will build. Like we will continue the work. And so I'm optimistic in how we together will move forward in these times of turmoil, and also optimistic about your role even in your nervousness. Like this is the reality that we have to sometimes step out of our comfort zone to keep the work going, and we have to sometimes worry about our livelihood because our livelihood is important to the work too, right? And so I wish you the best in finding a job, but go back to history, because in the 80s we saw the same thing happen, and those organizations that stood their ground, they survived, and those that pivoted too early did not. And so don't be quick to pivot. Stand your ground, do your work. For me, wherever your faith lies, wherever your security lies, keep that. Mine lies in God. And so I am like, I got to trust God, and I have to continue to do the work that is a part of my purpose because I'm here for this work, right? And so I think that those things are important, but don't be so quick to run scared, because those organizations did not survive last time this happened.
I think it's a little too early to tell, and maybe we'll have a better sense in, I don't know, 6 months, a year. No idea. I have been really intrigued to see if there would be some interest or in some of like the fertility related research. I know the Trump administration has spoken a lot about IVF. I think they laid off their entire fertility team at CDC. So we'll see if that ends up being something that's an important research agenda for them. There's a lot of questions in fertility care and treatment, how people are using it, surrogacy. All of those are important questions around reproductive health and justice. So that could potentially be an area where we see some interest in from the federal government.
Hi, thank you. I work in family home visiting, and one statistic that stuck out, Noya, in your presentation is that 2/3 of maternal deaths are happening between 6 weeks and a year postpartum. And I think we hear so much about what's happening like in pregnancy and immediate postpartum. So I'm just curious, like what's happening in that other window? And Dr. Smith, do you see the same statistics in Kansas? And how can we do better at supporting families in that time period?
Well, I think if you look at the time period in combination with the leading causes of death, it really all points to that mental health and substance use issues. I think whoever figures out the substance and opioid problem, they'll win a Nobel Peace Prize. I think we just have to continue to provide everything that we know that works as much as possible and make it available to as many people as possible. Statistics say that if you are addicted to opioids, you will go to treatment at least 6 times before it sticks. We need to make it possible for people to go to treatment 6 times. We need to make it possible for women with children and families to be able to go to treatment and still have those children with them or when they get done with treatment. Minneapolis and St. Paul are full of encampments that are full of people who are dealing with drug issues. People who make a decision to try to help themselves will make it in the middle of the night, and someone needs to be there to help them get to treatment in the middle of the night. And treatment needs to be ready to take them in the middle of the night. And know that they might fail because this is attempt number 1, or they might fail because this is attempt number 3, or they may be successful because this is attempt number 5. The whole system is too segmented, right? Like there's treatment, there's the getting into treatment, there's the aftercare, there's no connectors in between those spaces, and there needs to be. The payment of it, the provision of Narcan, the provision of testing strips, harm reduction, treatment, aftercare, sober living, all of it in abundance. And we don't have that right now. When it comes to mental health, someone said this, I think we don't even know COVID, right? Like what kind of impact did COVID have on everybody's mental health? Like I think my son was a freshman in high school when he got sent home. I see every day that impacted him, but I can't put my finger on it yet, right? But I just see it and how he's living his 20-year-old life. I see it in the people that work for me. I see it in myself, right? Like I'm like still these things that happen every day that remind me of how I felt in 2020 in June when we were trying to deal with COVID and we were trying to deal with George Floyd being murdered, and we were trying to deal with the explosion of homeless encampments, and we were, all of that stuff. And like mental health is such a huge need right now across the board. And we could train and train and train mental health providers, and there's still not going to be enough. So we as communities need to figure out what are the other ways that we can support people's mental health that doesn't involve getting on a long waiting list to see a mental health provider. Like we should still do that. I go see someone every week. I'm fully behind getting that kind of care. But there's not enough of that right now, so we need to figure out other ways to attend to folks' mental health. And when we're talking about pregnant women, women of color, it's not just about that postpartum depression. It's not, like that's a drop in the bucket of all of the mental health needs that they have. And so we just need to be attending to it during pregnancy and after pregnancy, but all the time. And again, I think it is about how do we equip community and family and circles that surround people to help them help each other.
I think mental health is mental wealth. And I think I second everything said. I just want to add one thing to that. We need to normalize mental well-being and we need to remove the stereotypes. I see a counselor monthly. It's called a life coach, but it's basically counseling, right? We need to normalize counseling or getting help or having conversations about our mental health and well-being. But the other thing that we see, yes, in maternal health, the number one cause is mental health and substance abuse. But at number two is cardiovascular disease that we have seen for centuries. And in that cardiovascular disease, we talk about weathering stress on the Black body, the historical perspective. We need to keep that in mind that that cause of maternal mortality has not changed for us significantly. We see the increase in mental health. We expect that being that we had COVID-19 and all of the fears. But how do we improve cardiovascular outcomes for pregnant women? What does that work look like is something that we need to focus on, and how can we begin to address that, because that is a continuous cause of maternal mortality. And when you do chart reviews in the hospital, you see more cardiovascular disease than anything. That's high blood pressure, and other things. And so we really need to be able to address those things too. But yes, when it comes to mental health, stop the stigmas, because mental health is something that every person experiences, right? In some shape, form, or another. And we need to normalize uh, getting help for that and normalize being mentally healthy and be more accepting, rather than being discriminatory against those that have a substance use. I review files and I'm in quality improvement meetings and I'm like, drug use, this, we're talking about a patient that has drug use, but we're talking about cannabis, right? And it's so discriminatory that it's blaming language too. Like, how do we address the root cause of this and not just talk about the issue? Like, what is getting you to substance abuse? Oftentimes it's self-medicating, right? And what causes you to self-medicate? How do we address those things by making people feel comfortable coming into our hospitals and our clinics or whatever places that are providing care? And stop reporting people because they're not going to come back. If you're going to report to DCF that I'm using cannabis in a legal state, and I didn't know I was pregnant, then I'm not going to come back for care. So we got to figure out how to care for people in the way that we haven't traditionally done. This is where I tell you guys, rebuilding is going to be important, and using your optimism is going to be important for this. But we got to care for them. We got to address cardiovascular health and chronic stress. And right now, we're probably all weathering the politics of today, right? And and what's going to happen in the morning, like we every one of us wakes up thinking, okay, what's happening today? So we're weathering every day, and how do we begin to address that so that we no longer have these high rates of cardiovascular disease? Thank you.
I'm hoping someone's monitoring the chat for us still, because I know there's questions or comments popping up, but I cannot access them from up here. So it'd be really helpful if someone could help with that. There's another question here in front.
Again, now is maybe not the right time to ask about like what research is going to be done or whatever about this, but one of the things that came up in particular in the Minnesota piece, and I think that it's kind of a big missing point, is the homicide component of this, and also men and fathers' roles. And Dr. Smith, you mentioned support for that, but I'm wondering what am I asking? What is the role, or how is our role of working in public health in, well, that's me, in maternal health to support men and fathers who are also having mental health concerns or things like that that are potentially causing violence or other concerns with women and children?
I want to take that one if I can.
I would point out, I would point out a couple things here. Ramsey County I don't know if there's any Ramsey County folks here. Dad Club? Yes, yes.
Yes.
I'm not great at remembering names. I have his card somewhere. Yes.
Thomas Chapman, I'll put it in the chat.
They're doing some really good work with fathers in Ramsey County, and that's exciting to see. The work that we do, maternal and child health, doesn't really open doors for being inclusive of fathers, but I think one thing that we have talked about is where are the spaces and places where we could, like, legitimately include fathers in the conversation. I think part of it is, I talked a lot about the maternal mortality reviews. Those deaths are leaving a father somewhere in the picture. And how do we include them in that story of the death and of the healing and recovery from that? And I do think there is some good fathers work going on. We need to do more of it, and we need to be very intentional about figuring out where to include that. I think one of our, in our home visiting program, we have this promising practices pot of money, which is home visiting done not using one of the best or evidence-informed curriculums that we support. And one of those home visiting promising practices is working with fathers. And I know that there's an organization that is training father doulas here in the Twin Cities. So I know that there's good work going on. We just need to, again, be more intentional about supporting it and finding space for fathers in this work that we do.
Yeah, I totally agree. So I was gonna say 1 in 10 men suffer from postpartum anxiety or depression, but there's no P in MCH. So I think we have to begin to put the P in MCH. I used to say D, but nobody liked that. I wasn't trying. I was just saying that. But I was just saying that. Like, I didn't even catch it. But put maternal, paternal, and child health, right, in the realities of doing that. And there are also no mechanisms in place for screening fathers, right? We don't have a mechanism in place to determine if they are suffering from postpartum anxiety or depression. And that is something that we have to change clinically. And that's going to be in our rebuilding of the system. How do we support families? I think the other thing, we do a barbershop initiative. And so that barbershop initiative is our opportunity to bring mental health specialists and fathers together to have safe conversations around this, like what they're experiencing. And then what's the best mechanism that we can do or put in place to screen them? But there are doulos, those are dad doulas, and you can find those, or your state has dad doulos. And they don't actually, do all the pregnancy stuff. So they are not, being invasive in any way, but they support dad, they support mom. In having that, we also have to normalize the presence of fathers in our clinical. We hear our fathers say they're not recognized, they're not spoken to, they just, no one sees them as the support person. So we have to change that as well, or whoever is with the parent. Or just because a parent comes to the doctor by themselves does not mean they're single. It may mean that one person has to work and they're coming to get an appointment. So we have to really meet fathers where they are and talk and have those conversations with them, but also make sure that there's father representation in our organizations. Like at the Barbershop Initiative, they don't want me to come. They don't want me. They told me, like, don't come. Right. And so I had to partner with a researcher to help lead this initiative that identified with them. Right. And so you can't go into these communities without, and people always say, oh, I was welcome in the community. You may be welcome, but do they feel safe to share the real stories and have the real conversations around you. And so that we have to begin to bring in the people that will allow that to happen and build partnerships around that. But yes, you are in public health. And yes, you should be thinking about the paternal factor. And yes, you are going to be a part of the new public health. So how do you engage fathers, starting now so that it doesn't look like it does today?
I just want to add to that, it also should start way earlier. I mean, we need a big cultural reset on what the role of men is in family planning and thinking about family formation. It shouldn't be the first time that somebody's thinking about their fertility is when they're trying to get pregnant, and thinking about the role of contraception and contraceptive burden. There's a lot of really great literature on that. We're maybe 5 years out from male birth control being on the market. And hopefully that means that there will be some changes in how people think about responsibility around what their role is as partners. And, so we're seeing all this emerging research about what the role of the father is as far as biologically with, the formation of the placenta and, the role, what some of those impacts are. And I think we really need to include them as a part of this conversation. That's really what it comes down to. Your first point was on intimate partner violence. As far as research that goes, I would recommend looking at Dr. Katie Cosmonell's work here at the U, quite a bit of work on intimate partner violence and pregnancy. That is a really hard thing to research. As far as being able to understand how common and how frequent that is beyond just kind of the seeing, maternal deaths as a cause of that, how frequent that happens. I know there's some like screening tools that are available to really look at that for people that are coming into clinical spaces, but it's a very hard thing to measure for sure.
One thing I just wanted to add was that for research in this area of maternal health in general, and especially mental health is, while we do have a prescribed, approved medication for postpartum depression, there's a huge equity issue around the fact that drugs that are needed for pregnant and postpartum people are not studied, and their utility, their safety, their effectiveness, it is systematically excluded for supposedly safety reasons. Yeah, and guess what? Then people are still needing to take those drugs, and we don't know how they're going to work, and the pharmacokinetics, and a person's body changes in terms of all of those metabolic features during pregnancy, during lactation. It's a huge problem, I think. I don't know what anyone else here thinks, but I mean, that is if you're thinking about areas to go into, if you're on the kind of clinical trial side of research, I mean, I think that's a big area. I don't know.
And it's a double whammy too, because there's a disproportionate burden of being chronically ill on women and people with uteri. So thinking about like autoimmune diseases, a lot of the drugs that we've been able to have that help alleviate some of those symptoms, and our treatments for that are not tested in pregnant people, and leaves those people really with limited choices around what their options are when they do get pregnant or want to be pregnant one day.
I have a question. It shifts gears a little bit about reproductive justice and access to abortion. So after the Dobbs decision, it got me thinking about, whether we can rely on the federal government for reproductive justice and the rights around that. And so I kind of want to know your thoughts about like the state-by-state approach, which was originally Ruth Bader Ginsburg's opinion that we should have gone state by state at first, at least. And I mean, I don't have an opinion about it, so I'm just asking what you think about that. And then the other piece of that is the religious rights aspect, because there are certain religions, many religions actually, that are, in favor of abortion because the mother, the pregnant person is the one whose life is at risk for whatever reason, and that decision is based on, what that person's needs are. And so is that an argument that could get up to the Supreme Court and prove it wrong because of the religious rights argument?
Well, I'll start with the first question. It's interesting because right now we are seeing a very different trajectory happening in Latin America with the Green Wave movement. They've been able to decriminalize and in some cases legalize abortion access. And their approach has been exact opposite of ours. It's very grassroots oriented. It really focused on winning hearts and minds, personal stories, creating networks of women and communities that were supporting each other. And, it reached a critical point to the point where, that was something that became culturally acceptable and therefore something that was supported through policy. We kind of have a up-down approach when we think of our reproductive health organizations. They have a very large role in how we think about policy and how we think about care. Planned Parenthood as being synonymous to abortion care in the US is a really great example of that. And less of kind of the power at the grassroots level. We have amazing history of organizing, but we just have not given we haven't given our community members that sort of role as being part of the table, and not even just part of a seat at the table, but leading the table around reproductive health and rights and justice in the same way we've seen in Latin America. So I think there's a great argument to be made about what does it mean to be more localized and the personal is political. Your second question was about Supreme Court. Yeah, I've heard this argument before about the religious rights perspective. I have not heard of any cases that are really explicitly challenging that are on the pipeline to the Supreme Court. If other folks know, please share. But I'm pessimistic. I'm very pessimistic that would work as an argument.
Great. Yeah, lots of incredible questions, and more questions than answers as always, but excellent questions. I want to make sure others have time to ask one more question, and then we could have some final comments and takeaways from our panelists. Great, we have a question back there in the middle of the room.
Thank you all for the presentation. We talk a lot about social justice and also about equity. And I'm wondering how we can better reach out to the communities that doesn't believe in equity or this kind of frames, and even eventually get more support from those communities.
Can you repeat? That doesn't believe in
Equity.
Equity. Sorry,
Yeah.
I'll start by saying I'm not in the right headspace to really be thinking there's any hope. But I do think of, I have a fair number of people in my circle, in my immediate family, who in November went to the ballot box and voted against my interests. And as time is progressing and things are happening, I'm seeing tiny little bubbles of not regret about their vote, but maybe second guessing some of the things that are happening at the federal level. And my mother is one of them. And I was visiting her this last weekend, and she was talking, and I'm like, I think she's seeing the light, just a tiny little bit. And that doesn't invite me to go full force in, but it invites me to plop out just a couple little bits of information, to take advantage of the fact that she kind of opened the door and said a couple things that allows me to put a little bit more information into her plate for her to think and consider. Will it change her mind? I don't know. I hope so. But I think that that's kind of the approach, right? Like, we have to be watching for those little open doors of opportunity